Good afternoon, everyone. Welcome to today's Research America's Alliance discussion. I'm Savannah Sims, and I'd like to thank you for joining on Zoom today and for your partnership in the Research America Alliance. Before we get started, just a little administrative housekeeping. If your organization is not a member, I hope you'll shoot Joel, our Director of Membership, an email to discuss the work of our Alliance and how much we value your involvement. His email will be in the chat. Please also remember to type your questions in the Q&A box, and we'll pose as many of those as we can get to during the Q&A portion of our discussion after our wonderful presentation today. So today, I'm pleased to welcome two influential rural health experts from the University of Illinois Rockford, Dr. Brianna Sheppard and Dr. Heidi Olson. We have invited Dr. Sheppard and Dr. Olson to discuss their work focused on rural health at the University of Illinois Rockford. Their work in rural health research is emblematic of the broader health needs that extend not only across our nation, but across the globe. So with that being said, we would like to extend once again our appreciation to Dr. Olson and Dr. Sheppard for joining us today, and I will pass it over to them. So the floor is now yours.
Hi, I'm Dr. Heidi Olson. I'm a clinical pharmacist and director of our rural pharmacy program.
Hi, I am Dr. Brianna Sheppard. I am Associate Director for Rural Health Workforce and Center Development here at the College of Medicine in the National Center for Rural Health Professions.
All right, next slide. I think maybe one slide before that, sorry. Oh, all right. That next slide, we'll just go ahead and get started with it. All right, so we want to just start off by giving everyone a little bit of context and defining what rural is. So there's quite a few definitions and they're all varied. So the Census Bureau defines rural as any population that has less than 2,500 people. The Office of Management and Budget and also the 2002 Farm Bill defines rural as any one city with a population of less than 50,000 people. And still different is the Department of Veterans Affairs definition, which is a population density of less than 1,000 people per square mile. And then we have the RUCA code, or Rural Urban Commuting Area Codes, that is based on the population of a community and its functional relationship between other places as measured by work commuting data. So here you see just an example of some of the varieties of ways that rural communities are defined. And so to put that into context, let's look at rural in Illinois. So Illinois has 102 counties. Of those counties, 84 of those counties are rural. That makes approximately 80% of the counties rural. And 75 of those rural counties are considered medically underserved. So that accounts for about 90% of the rural counties in Illinois are medically underserved. Next slide, please. All right, so we also wanted to give you a little bit of background on the history of UIC's Health Sciences campus, which is located in Rockford, and it was established in 1971. And then in 1993, the Rural Medical Education Program started, also known as RMED. And 10 years later, the National Center for Rural Health Professions was created. And in 2010, we started the Rural Pharmacy Education Program, or RPharm. And along with RMED, we created the Rural Health Professions Program also in 2010. In 2010, the Illinois AHEC network was created. Then in 2015, the Behavioral Health Workforce Education, Leadership, and Learning Program started. And in 2017, the Rural Nursing Program started, also known as R-Nursing. So you can see we do have a long history of being involved with rural health professions and rural health professions education. Next slide, please. So the Rural Health Professions Program is something that was started once we had more than one profession on our campus. So RMED and RPharm both work together in collaboration to create an interprofessional program. And Illinois Be Well and then the R-Nursing program were also added. So as each program was added, the content was modified to help meet our interprofessional audience's needs. And I'm sure anyone who's experienced working with multiple schedules, some challenges came up just simply by scheduling with programs from 4 different portions of the university, and then also different curricular needs. So that's always a challenge when you're working with multiple people, and especially a challenge when you're working with multiple programs. Next slide, please. All right, so I did want to talk a little bit about the Our Farm program goals. So we do want to recruit students from rural and underrepresented minority populations and help them prepare for practice in rural communities. I grew up in a rural community myself, and I always say, who better to take care of a rural community than someone who has grown up in a rural community and understands the nuances of what that means. And with the program, with Our Farm joining Our Med, we knew that we needed to create and implement interprofessional teaching models in order to make sure that we are meeting the needs of rural communities, meaning our students that graduate from our programs are able to communicate clearly and work well with teams made up of different healthcare professions. And we wanted to promote quality programs and services to rural populations. Our students are trained to practice evidence-based medicine and be up to date on the most current recommendations and guidelines. So we wanted to make sure that we're bringing that forth to rural communities as well. And finally, we wanted to help retain our rural workforce in those rural communities. It's really tough on a rural community to have a healthcare professional that comes in, stays for maybe a year or two just to get a little bit of experience and then leaves. So our goal is to have our graduates go into a community, become part of that community, and stay there. Next slide, please. So the way that Our Farm program is set up is our students take one rural pharmacy elective course every semester for the first 3 courses. And these courses touch on public health topics. And then they also look at topics that are commonly covered in the core curriculum for a PharmD program. And then we look at it from a rural lens. So things like rural ethics and rural mental health care are going to look slightly different given the small community that they take place in. And then after 3 years of classwork, when our pharmacy students get into their 4th year, they're going to do hands-on experiences that entire time. And our Farm students do 18 weeks of hands-on learning in the same rural community. And during that time, they're going to learn what 3 different types of pharmacy look like within that same rural community. And while they're in that rural community getting their immersion experience, they're going to work jointly with their RMed partner to implement a community-based research project. And that project is something that the students and their advisor have been working on for at least 9 months to get ready to go. And then upon graduation, our Farm students are going to graduate with their PharmD, just like everyone else in their class, but they're also going to graduate with a concentration in rural pharmacy services, which is the professional school equivalent to a minor. Next slide, please. So to date, we have graduated 10 classes of Our Farm graduates, and we have 61 graduates out practicing. 44% of our graduates are practicing in community pharmacy, and 37% of them are practicing in a health system pharmacy, so something like a hospital or ambulatory care clinics. 70% of our graduates are practicing in rural locations. And interestingly enough, we found that our graduates often practice very close to home. So 70% of our graduates are practicing within 100 miles of their hometown. And 71% are working in the state of Illinois. And you can see the map on the right. All of the highlighted blue counties or states show where we have graduates currently practicing and living. So you can see they're in various parts of Illinois, but they're also spread throughout the country. Next slide, please.
And thank you so much, Dr. Olson. And I am part of the National Center for Rural Health Professions, which houses the Rural Medical Education Program. That's part of Rural Health Professions that Dr. Olson just described. And we really take a holistic approach to improving the health and wellness of communities through education, service research, and policy, and really focusing on not just what we're doing, but how we're doing and how it's making an impact. Next slide, please. So in our three main buckets, if you will, we do quite a bit of research and program evaluation around education and workforce development. We have several pipeline and pathways programs, one of which is the Illinois Area Health Education Center program. This is actually a national program that is funded by the Health Services and Resources Administration. So most states have an AHEC, and they really focus on addressing workforce shortages and recruiting and retaining individuals who are underrepresented in health professions and providing them with extra opportunities and enhanced educational opportunities to continue to inspire them and ideally have them decide to practice in a rural or underserved area of their state when they graduate. We also do a lot of curriculum development and evaluation for rural undergraduate and graduate health professions education, and continuing education for rural health providers in practice. Next slide, please. So just to give you a little bit of idea of where some of our graduates are at and how we are approaching assessing equity and access to pathways and pipeline programs, with the idea of using these types of opportunities to increase the number of students from rural backgrounds and underserved backgrounds that choose practice in a rural area, which research shows those students are more than twice as likely to choose rural practice, and also providing training opportunities for those who may not be from a rural underserved area, but are provided opportunities to train in rural areas, are almost twice as likely to choose rural practice. So giving RMed as an example, and there are lots of different rural focused training programs across the country. There are about 70 in medicine specifically. Next slide. So where are our RMed students at? We've graduated 407 since the program started about 30 years ago. About 65% are practicing in a rural area. Almost all of them were from a rural background. More than half are in Illinois, and 94% of those are outside of Chicago and the surrounding counties. One of the unique things about RMed and some of the other rural focused programs that medical schools offer across the country are the choice of primary care residencies. We have graduated a lot of family medicine physicians. 19 out of 20 of our RMed physicians are practicing a primary care profession currently. And 88% of those are providing primary care to rural residents in Illinois. So building in that research of not only how our curriculum is impacting our student service orientation, but understanding what the outcomes for those programs are in terms of eventual practice outcome are incredibly important for resource allocation and fine-tuning our recruitment and retention strategies. Next slide. We are also really involved in policy. We've done quite a bit around rural health workforce development and road mapping within the state and nationally. We do some policy briefs, essays, op-eds, and then we are really active on state, local, and national as well as global committees, because it really is a systems approach to using data to drive changes in programs and policies to address rural health disparities. Next slide. So some of the focuses of our research are equity and access to those training programs. So who are we recruiting? Where are we recruiting them from? Have they been provided opportunities to get the experience with exposure to health careers before they ever make a decision about what health profession they may want to pursue? So we start as early as middle school with different pipeline programs. We examine how social accountability and community-based interprofessional training really contributes to retention of healthcare providers in rural areas. As Dr. Olson mentioned, all of our students complete community-oriented primary care research projects. So really giving them an opportunity and the tools to understand how they, as future healthcare providers in a community, can be leaders and help to drive some of those data, how help find that data or collect that data and use that data as part of a larger collaborative in a community to find the gaps for resources and address policies and programs to fill those gaps that they've identified that might be contributing to rural health disparities at their local level. We also do a lot of work around factors that predict rural practice, particularly in medicine, and then retention of rural health providers. Next slide. So why is research important, especially in rural health? Research is important for decision making. You'll see a quote here from Christine Sand, who's at the Rural Health Information Hub. If you don't know what the situation is, if you don't have data to back it up, it's really hard to make a case for why you need something or why you don't need something or why a program or policy needs to change. And it's really about health equity. To increase health equity across our rural communities, we need to assess what's going on. We need to work together, and we need research to back up what those proposed changes are going to be. Next slide. So as Dr. Olson alluded to at the beginning with her example in Illinois specifically, there are a lot of different definitions of rural that show up in the research literature. What you see here is a study from 2021 where they did a really nice comparison of each of these different types of definitions of rural and how they impact the severity of what we see as rural health disparities. So based on each of these different definitions, how many people are considered rural varied a lot depending upon the definition that was used. So most definitions that you see listed here agree on what is urban, but they have a lot of disagreement about what areas are actually rural. So some of the core-based statistical analyses, so that third bullet point down, tends to be a more liberal definition of rural, more of metro versus non-metro, or that 50,000 or less. Dr. Olson had alluded to, and that definition shows more significant health disparities when you compare rural residents to urban residents on things such as cancer prevalence, incidence, other chronic conditions. RUCA codes, the rural urban continuum codes, and the rural urban commuting codes take into account how close different communities are to more urban centers. And these are the definitions that are typically used in the workforce literature, especially when looking at workforce shortages. And in this particular paper, the authors concluded that the definition of rural that you should use depends on the goals of the program that you have, whether it's workforce, whether it's chronic conditions, in order to be able to make comparisons to what was found in the literature previously. So one of the things that we've started doing, and I've seen happen a little bit more often in the literature to date, is people are using kind of more than one definition of rural to understand what those differences might be. Next slide.
Yes, so talking about some of the rural health challenges, there is a lack of data about what proportion of rural students are in pharmacy school, and also a lack of data on what the predictors of rural practice are.
In a similar vein, a study in 2017 showed that less than 5% of all incoming medical students were from rural areas, and there's a robust literature for medical students that shows individuals from rural areas are the most likely to go back and practice there. So we're not leveraging that recruitment pool that we have seen over the last several decades are the most likely to help fill those provider gaps.
And another challenge, when we look at the number of retail pharmacies from 2003 to 2021, the number of those retail pharmacies decreased by almost 10% during that time frame. But in more urban and metro areas, retail pharmacies increased by 15% during that same time period.
Additionally, and compounded by the COVID-19 epidemic, we've seen a lot of rural hospital closures and risks and a lot of change in the service mixes that are being provided by rural hospitals now, including a reduction in the number of hospitals that are offering prenatal and maternal care and inpatient pediatric care. So there are more than 99 million Americans that live in an area that don't have enough primary medical care providers, and 65% of those are rural. According to a 2017 report from the U.S. Government Accountability Office, physicians, only 10% of them choose to practice in a rural setting. Unclear of how many pharmacists in this role. So there's really a lack of data around other health professionals, where they go, why they go, and how that contributes to rural health disparities. So that's definitely an area ripe for research. Perhaps most importantly, mortality rates between rural and urban residents has increased by 12% over the last 10 years. Next slide. So good news, the recognition of the importance and the need for up-to-date and assessment and research around rural health is reflected in federal funding for rural research. So most of the major centers and divisions across the federal offices do provide some sort of rural focused funding for rural. Some funding announcements and programs will specifically identify rural or rural health, such as HRSA's Federal Office for Rural Health Policy, like the Rural Community Opioid Response Grant programs. And there's also rural residency and training programs. SAMHSA has developed and implemented rural EMS training grants, and the USDA has rural development program grants that address not just agricultural, but also farmer rural mental health, as we've seen a significant increase in suicide rates in this specific rural population. Many of the FOAs from these different organizations include addressing underserved and underrepresented populations, and rural is now typically included in that definition of underrepresented. Next slide. So we wanted to end on a positive note, and so research is really important, but part of building a strong rural health network. So one of the things we're hoping to do locally is to create a more formal rural health sciences training campus here in Rockford, adding dentistry, social work, and dietetics, as well as other allied health professions to the Rockford campus.
And on the pharmacy side of things, over probably the last 5-6 years, I think many of us in rural pharmacy education have realized we're not the only ones doing this. There are at least 16 other colleges of pharmacy that have a rural pharmacy education program, and many more that are doing at least some kind of education or training in rural areas. So we've created a consortium, a rural pharmacy consortium, so that we can help support not only faculty and students that are in rural pharmacy, but also pharmacists that are in rural pharmacy, and help us to be aware of what's going on the front line, so that they can share their knowledge with the rest of us. As mentioned before, the data on workforce for almost any profession other than medicine is sparse at best. That includes pharmacy. Figuring out predictors of why they go, where they go, is difficult. And while a group of us were presenting our outcomes results for our rural pharmacy programs at NRHA, we spoke with one of the researchers with WWAMI about the lack of workforce data for pharmacists and what could potentially be done to help get that going again. I think a lot of people are aware of the term pharmacy deserts. There has been some research on the existence of pharmacy deserts in both urban and rural areas, but a pharmacy desert doesn't necessarily equate to having enough pharmacists, and having a pharmacy desert having a pharmacy desert in your area doesn't mean you don't have enough pharmacists, and the converse is true. So if you don't have a pharmacy desert, that doesn't mean that there are plenty of pharmacists in your area. So it's hard to have one piece of information without the other to really make a strong conclusion.
One of the exciting things that we've seen and have been able to be a part of, especially over the last several years, is we've seen that expansion of rural health research networks, regionally, nationally, and globally. Just to give you a few examples here, the Appalachian Translational Research Network was established back in 2012, and that group comes together once a year to share best practices and knowledge and information about information they're finding in Appalachia, including rural Appalachia, about what's working and what's not to improve health and drive health equity. There are a lot of practice-based research networks that have created some special interest groups. Some of these are funded by NIH. Some of these have kind of developed independently, but all of them are really developing consortiums working together to use research in clinical medicine to drive programmatic and patient-level improvements. The National Rural Health Association has lots of connections and collaborations and is really kind of a meeting place for folks to come together across different disciplines and different systems to support not just research collaborations, but also changes in policy that may be positively or negatively impacting health for rural Americans. And then another example globally is the Pan American Organization, the World Health Organization for Primary Care, of which the National Center is a collaborating center. There are 3 of those in the US, and we come together as a group with partners from our South American neighbors to strategize and share best practices about recruitment, retention, and developing ways to address not just healthcare provider shortages, but all of the other systems level impacts that can affect individual and population level health. Next slide. So just to try to sum up, research is critical to understanding not just what health disparities are and how to increase health equity, but what the mechanisms that are driving those health disparities are. And it's important to look at it at multiple levels, from the local level, which Dr. Olson and I have gave some examples today, through the national and global population health levels. And it's also important to do so across disciplines. Not just health, but across economics, across policy, across infrastructure. So we can help to address those systems level factors that are contributing to either the health or increased mortality that we indicated for different rural communities. And each rural community is different. So having that community engaged participatory research as a significant component of overall rural health research that goes on from case study to population health level is incredibly important, so that the policies and programs and services that are implemented are reflective of community needs. And here you can see our contact information, and we're happy to take any questions you will have.
Thank you both so much for such a fantastic presentation. So just a reminder to the audience, please feel free to keep putting questions in the chat and we'll get to those. I see we already have a couple great ones. So, but I wanted to kick off with a few questions that I thought of as you were speaking. So, I just wanted to first say thank you again for all of your important work in this field. I think it's so exciting. And so just to kick off, Dr. Olson, I know you mentioned how you grew up in a rural community and how retaining the talent is so important. And, on top of that, Dr. Sheppard, you mentioned how, the people that grow up in rural communities are more likely to stay and serve those communities and how important that is. And so I also grew up in a rural community, so it's especially near and dear to my heart. But, so you mentioned that these rural areas are struggling to attract and retain researchers and healthcare providers. And I know you talked a little bit about these strategies, but I was hoping that you could just expand on these strategies that can be employed, and, if that relates to any policies in place to start incentivizing, students from rural communities to stay in this career path and ensure that sustainable healthcare workforce in these rural communities.
Me unmute myself. I don't mind to start. And so for a lot of programs, there are opportunities for facilitated admissions to different health professions programs. So having a pathway into medical school or pharmacy school or nursing school, where at least a certain number of slots are dedicated to rural student interviews, to give them the opportunity to interview, as they may not have had the same opportunities as some of their urban counterparts for experiences that make them competitive applicants. So, identifying ways to start early exposure in middle school through high school for pipeline programs, offering shadowing opportunities at those levels as well as the undergraduate level, providing those immersive rural health experiences. Here we call it the rural health experience, where students from rural backgrounds can apply to shadow with a physician for 2 to 3 days, or sometimes up to 16 weeks.
Wow, yeah.
Get that really intensive experience that they may not get because they may not have a family member who is a healthcare provider, or they may not have access any other way to get that experience that's required to be competitive for these types of health profession schools. So there are lots of foundation support for some of these programs, Educational Foundation, Healthcare Foundation, that have helped supported the health services, and the HRSA grants. AHEC is another good example of kind of that pipeline opportunity. And then providing different doses of training while they're in professional school once they've had an opportunity to get through that facilitated pathway. So really reinforcing what rural medicine is and why it matters. Dr. Olson, anything you want to add?
Yeah, loan repayment, I think, is an important attractive mechanism for someone to want to work in a rural community. The stats say somewhere like 80% of pharmacy students are taking out loans for pharmacy school, and up on graduation, the average amount of loans is $160,000. So knowing that they're going someplace that is going to invest in them, essentially, I think is a big incentive. And again, making people aware, and this is talking like middle school, high school, college age kids, making them aware that, one, pharmacy is an option, it's an attainable option, and two, that it's something that they can do and then come back to their rural community and give back. So if they're wanting to stay rural, you can go to school, become this expert, and then come back and provide care to your community.
Right. No, that's fantastic. Thank you both so much for, that's such an important area. And kind of to kick off from that, of course, at Research America, one of our main initiatives is advocating for change based on these research findings of, the people like you are doing. And so I just wanted to know if you have advice and what your thoughts are on how we can effectively translate your research findings, the programs that you are working in about these health disparities into policy change, and how can we really garner support for these initiatives, and what key messages or evidence should we be emphasizing for these vital initiatives?
Sure. So I think trust is key, and having that open conversation about what are, what are their perspectives on what's working and what's not? And is that, are they aware of the data? If they're not aware of the data, being willing to share the data.
Yeah.
And then just keeping an open line of communication about what data is needed to answer the questions required to change policies or programs. So for example, before I started at the National Center, I was at the West Virginia University Health Affairs Institute, and it's one of several formal state university partnerships that have developed over the last several years to help address just that. So we worked very closely with the Department of Health and Human Resources, both on access to direct services, but also around healthcare workforce issues, including recruitment and retention. And, we were able to talk with them, understand information they had that maybe we didn't know as a government entity versus an academic entity, and then create a plan together to collect the data that was needed to impact change at a policy level. So kind of a specific example around that is we spent about 2.5 years doing a pretty in-depth needs assessment for substance use disorder services that were available in the state, and making sure that we pay close attention to rural populations, as West Virginia is very rural state comparatively, and then working together to identify successful models in other states and develop our own model that's now being tested for a new Medicaid provider type that they're currently evaluating. And then ideally we'll put forth as part of their state plan amendment to get federal support for that. So adjustments at the federal policy level to support that increase of access for rural populations specifically, where that infrastructure didn't exist before. So it's a long process, and it requires a lot of trust and willingness to listen and not just be heard. So for me, that's really a critical component, whether you're doing it at a state policy level or whether you're doing it at a local community level.
I think that's so important, and to also highlight, that it happens at all of those different levels. And so, we have to be thinking about it from the community, the state, the nation, and ultimately, everywhere around the world. So, as much as I would like to continue asking questions, I'm going to ask my colleague Jacqueline to join us on screen, because we do have some great questions in the audience that I want to make sure we get to.
Great. Thank you, Savannah, and thank you, Dr. Sheppard and Dr. Olson, for this fantastic presentation. We have a lot of great questions coming in. First question, what non-federal funding sources are out there for rural health research?
So there are some larger foundations. Robert Wood Johnson Foundation, for one, if the focus is on health equity, that's a great place to potentially partner. Each state has kind of its own state, local, or regional foundations that you can check with. Some hospitals have foundations as well that are great partners, especially when you're working at that community population health level to address rural health disparities. I'm trying to think if there are kind of other innovative ones. There's some state funding. Depending upon kind of what your focus is, there are some state departments of health that have block grants from larger federal entities that they will release RFAs for that might fit your wheelhouse. And so having a state contract or grant partnership is also there. And then sometimes your local, like the university that you're within, may also have internal opportunities for that as well. There are the Clinical and Translational Science Institutes that have been supported over the last 10 to 15 years, maybe go on 15 to 20. I feel like I've been in it for a long time. Also have pilot grant programs. And this last funding cycle, there was a significant emphasis on rural health as cross-cutting themes for a lot of those clinical and translational science institutes. So those are some places that you can look at to partner and identify funding for, in addition to federal grants. Dr.
The College of Pharmacy has been working for quite a few years now with the Community Foundation of Northern Illinois. So again, it's a local foundation but we've been able to get support for creating pharmacy pipeline and managing diabetes, and we do quite a bit of outreach at county fairs. So we're working on getting support for improving accessibility to services like that in our rural communities. So that's another resource that we've been fortunate enough to be able to utilize.
Great, thank you. That's great that there are so many opportunities. So next question. I'm curious about how this program has helped to expand the 340B program in rural areas.
So 340B, from pharmacy perspective, it's something that's set up within an individual, either healthcare system or site. So our program itself has not been involved in helping individual sites get that set up. I know that our graduates, that's something that's covered in their core curriculum. So when our RFarm graduates are going out into a rural community, that is something that I'm sure they're asking about and trying to figure out, does part of our community meet the qualifications to be part of that program? And if so, can we get that up and going? I know we have some pharmacists in rural communities where that is their only job, is to maintain the 340B for that area.
In terms of the National Center, the work that we've done around that to date has really been as part of those committees and active working groups, including partnerships with the Illinois Critical Access Hospital Network, the National Rural Health Association, who are really good at getting feedback from all of their different constituents and using that to inform the different policy and advocacy initiatives that they take on as national representatives for rural health.
Great, thank you. And I think we only have time for one more question. So this is also ending on a good note. How can health advocacy groups connect and be a resource?
Yes, and that's amazing. So for kind of rural health specifically, almost every state has its own rural health association, and that is a good mix of clinicians, community-based organizations, researchers, clinicians, folks who are working in government on the front lines of trying to address these from the individual patient level all the way through the state policy level. So my recommendation would be to find your state's rural health association and make some connections there.
And my suggestion would be, look at the state that you're in and maybe even the surrounding states to see which healthcare professions are included in their loan repayment programs and which are not, and see how that lines up with the needs in your state, to figure out, do we maybe need to advocate for including more of those professions that are needed in your region in the loan repayment programs. And those repayment programs differ by state for the state programs, and then also federally who is included and who is not included. That changes from year to year.
All right. Well, thank you so much, Jacqueline, for helping me field some of the audience Q&As. And unfortunately, I think that's all we will have time for. I know that I could sit here and ask questions and listen to your answers about this incredible work all day long. But I would like to thank both of you for all of your time and sharing your important work with us, and thank the audience for your thoughts and participation. So now I'll turn it over to Jacqueline to let you know about our next Alliance meeting.
Great. Thanks again, Savannah, and thanks Dr. Olson and Dr. Sheppard for this very important discussion, and to our audience for joining in. Next week, we're honored to host Dr. David Ridley from Duke University, whose groundbreaking research into market incentives to bridge the quote unquote valley of death in biomedical R&D investment has transformed the incentive landscape for private sector research and development. keep an eye on your emails for more info and the link to register, which is also in the chat. Thanks again for joining and have a great afternoon. Bye.